This first day, second show of the AIOC meeting, and welcome first of all to my esteemed faculty and all of you who are here early in the morning for this preferred practices and controversies in pediatric cataract management. I am Dr. Vaishali Vasavada from Raghudeep Eye Hospital, Ahmedabad and Jaipur. And as you can see here, we have a star-studded lineup of speakers here, and I am sure we will make most of this opportunity, all of us, to interact with each other and ask questions and doubts and learn from each other. So I will start without much ado. We want to keep in time with my talk on IOL implantation in infants and children below the age of 2 years. What do we know by now? And I have no financial interest in this presentation. So I think we all understand that the objective of a pediatric cataract surgery is as much as a technical outcome and as equal amounts of functional outcome. And often it is this functional outcome in terms of trying to prevent amblyopia and stereopsis and binocularity. This is where we often lose the battle or we fall back in our management. So primary IOL implantation, I think we all understand that by now it is very, very much in vogue, and people implant in as young as children below the age of 2 years. But I think it is in the infants, and particularly those below the age of 12 to 18 months, that it is still, let's say it could be a controversy, not because of its scientific merit and demerit alone, but also because of many other factors, including your technical expertise, including the ability to follow up, and so on and so forth. So I think we all agree, I think experts around the world and across the globe agree that above the age of 2 years, it is safe to implant a primary IOL if you can do it in the capsular bag. And particularly in unilateral cataracts and more so below the age of 1 year, this IOL implantation still remains controversial. I think in my mind, at any age, whether it's a small baby or an older child, any child with a horizontal corneal diameter of 10 millimeter, it used to be 9.5 millimeter cutoff for me, but I have pushed it to 10 millimeter. Anybody who has microphthalmos, that means an axial length of less than 2 standard deviation for their age, and anybody who has intraoperative problems where you could not do the rexis the way you wanted, or you had a lot of iris tissue manipulation, and you feel that you are not 100% confident in putting the lens in the bag. I think this is one of the biggest contraindications that even if you had planned an IOL, even if you had counseled the patient, it makes sense to go back on your plan and leave the child aphakic. Now let's go on. Before we move on to my preferred strategy, let's see what the international literature says. So a lot of you might have heard of this infant aphakia treatment study and the American Academy report. They both have said that primary IOL implantation should not be performed when the child is under 6 months. And again, like I said, the IATS, which was a unilateral cataract study, at 10 years follow-up, they found more complications in terms of more resurgery rates in pseudophakic eyes. So the Western world seems to say that do not implant an IOL below the age of 6 months at least. But we live in a different geography, plus the fact that if you are an experienced surgeon and if you can follow up the child by rigorous examinations, performing anesthesia when needed, refractions, and take the child up for resurgery as and when needed, it may often be a better option in terms of an early visual rehabilitation. So again, another study where the toddler aphakia pseudophakia study, the TAP study, where again they said the same thing, that once you operate bilateral cataract in infants below the age of 1 year, then IOL increases the risk of a visual axis obscuration. Until a few years back, there was no evidence in literature in bilateral cataracts below the age of 2 years whether we should implant or we should leave them aphakic. A lot of us do believe even today that giving them aphakic glasses or contact lenses is as good an option as doing a primary IOL. But we did a randomized clinical trial published in the AJO in 2018, where we found that when you performed bilateral in the bag IOL implantation in cataracts below the age of 2 years or even below the age of 6 months, If you can do an in-the-bag IOL implantation, the complications were very similar except for a little higher incidence of posterior synechiae, which obviously are more visible when there is an IOL. We cannot see the mid-peripheral synechiae which may be occurring in aphakic eyes also. And in fact, the rate at which, this is very important, I want you to note, the rate at which vision developed in the early post-operative period, that means 18 months after surgery, there was a much faster visual recovery in pseudophakic eyes as compared to the aphakic eyes. Although finally at 5 years follow-up they reached the same point, but the steep climb was much higher in pseudophakic eyes. So I think the message that I want to give is that if you feel that you can technically achieve a good anterior posterior capsular opening, whatever method you may use, and then put an intraocular lens in the bag, then that should be performed in any eye that is anatomically suitable to take the IOL. The caveat being a rigorous follow-up, and often under anesthesia. You may need frequent EUAs to examine these children. Now let's go to the methodology. If you do decide to implant an IOL, what are the options available to us? I think we all understand and we all have been doing anterior posterior capsulorhexis and in the bag IOL along with an anterior vitrectomy. Now here again we have two good options. I don't think it should be an ego issue that you should be able to perform a manual posterior capsulorhexis of a fixed size and centration. You can also do an anterior rhexis, put an IOL in the bag, and then go with your vitrector from the pars plana route and do a pars plana capsulectomy vitrectomy. So this still is a very good option, putting the lens in the bag. Now material, without any financial bias, even today I think hydrophobic acrylic single piece IOLs are still the best choice because of the fact that they are time tested in terms of inflammation and the occurrence of visual axis obscuration. Like I said, there is no ego. Not everybody every time can perform a manual posterior capsulorhexis, no problem. In that case, perform an anterior rhexis, remove the lens material, implant the IOL in the bag, and then as you can see here, I have pre-implanted a trocar about 1.5 to 2 millimeters behind the limbus, through which I am introducing my 23 gauge vitrector. It's a regular phaco machine. It doesn't have to be a Venturi vitrector machine. And with the highest possible cut rate on your machine, you put the irrigation through the corneal side port and the vitrector goes behind the IOL and perform a capsulectomy vitrectomy. So the comfort of having achieved an in the bag lens is still there, and you are not worried that your PCCC was not of the right size and shape. So this is a very good option, and sometimes I do resort to it, particularly in children below the age of 6 months. But the last and the most important segment of my talk is, can we avoid this whole vitrectomy, which is supposed to be an integral part of cataract surgery, whether or not you implant an IOL? And which brings me to now our preferred technique across our hospitals, all surgeons, optic capture. Dr. Howard Gimbel was the first one who deserves all the credit for describing this technique in children. Basically, you perform an anterior posterior capsulorhexis, put a 3-piece lens in the capsular bag, and then push the optics of the optic of that IOL behind the posterior capsulorhexis. And here is a video to show you how it is performed. This is a standard white cataract in a pediatric eye, and you can see here that an anterior capsulorhexis is performed, a posterior capsulorhexis which is 4 to 4.5 millimeter. You don't need to measure, but it should be around that size. Now once this 3-piece lens is in the bag, I'm using my dialer or a Lester hook to just slide the optic behind the posterior capsulorhexis margin, and the same thing is being done here. So achieving this dumbbell sized appearance is the end point of a good optic capture of the IOL. But mind you, no anterior vitrectomy has been performed. I perform a triamcinolone staining after this just to make sure that there are no vitreous strands. And this is again a follow-up of the child 3 months following optic capture. And this is 1 year where you do see some phimosis coming up, but the central visual axis is absolutely clear. And these are pictures from 3 years follow-up from an EUA that has been performed, and again you can see crystal clear visual axis here. So what the optic capture does is basically the anterior and posterior capsule leaflets fuse and they block the proliferation of lens epithelial cells towards the center. But what it does as a by effect, which we realized later, is that a captured lens will be so stable in the capsular bag, as you can see through this animation, it will not move at all, versus an in the bag IOL is liable to move anterior posteriorly or laterally. So it locks the epithelial cells and it gives us extreme stability. We published a few years back 1 year outcomes of in the bag IOL and anterior vitrectomy versus optic capture and no anterior vitrectomy in pediatric eyes. And what we found was that the incidence of visual axis obscuration was nil in optic capture eyes, and they were both comparable in terms of their vision and complications. So I think optic capture, it's difficult to perform, it has a little steep learning curve, but if you can, please start doing it in older children. You can do away with one whole procedure of vitrectomy, which who knows what side effects it has in the long run in these children. So I think I would like to end my talk here by saying that start with older children, whatever the technique you use. And it is very, very important that we take in mind the complications, the ability to follow up the refractionist. We should have all the backup before we think of implanting in children below the age of 6 months. Thank you. Any quick questions or comments? Please. You can take the mic up there.
So, ma'am, in the technique of where you didn't do a vitrectomy, what was the IOL cover you chose? The same as that of the bag, or was it any?
So that's a very valid point, that when the effective lens position shifts a little posteriorly, you should ideally undercorrect your IOL a little bit. But in this case, because really pediatric eyes, particularly those below the age of 2 years, everything is such an enigma. We usually undercorrect by the standard age appropriate nomogram that we use. We don't make any alterations for the optic capture. But yeah, you could use about anyway you don't get steps less than half a diopter. So half a diopter you can adjust for that.
Maybe we need to do an RCT for that.
Absolutely.